Hello, everyone, and thank you for joining us today. Welcome to the American Medical Association's Private Practice Simple Solutions, part of the Steps Forward Innovation Academy. Before we get started with the content, a quick few housekeeping items. Next slide, please. The Private Practice Simple Solutions program is a series of rapid learning cycles designed to provide opportunities to implement actionable changes that can immediately increase efficiency. Next slide. Please note that this presentation has been recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Please take a moment to carefully review this notice. Next slide. I'd like to now introduce today's speaker, Dr. Brian Batson, who will be leading us through the content. Dr. Batson, please take it away.
Thank you, Symbol. It's a pleasure to be here. Appreciate the invitation. Today, I hope I'm able to provide some context for Hattiesburg Clinic's journey into value-based care. I am an internist by training, actually trained in med-peds and with a specialty in hypertension. I've been with Hattiesburg Clinic for just over 20 years now, serving in several administrative roles, Chief Medical Informatics Officer for a few years, and then Director of Value-Based Care, and most recently moved into the CEO position about 3.5 years ago. So I'm hopeful that today I can share our journey as Hattiesburg Clinic, as we had a goal of, and continue to have a goal of, remaining an independent practice, and some significant changes that we have made over the last several years in our journey in value-based care with a goal of remaining independent. So as we were looking at strategy as an organization, we wanted to try to frame a future where we were being mindful of value-based healthcare delivery and how that also intersects with the quadruple aim, something that's really important to us as an organization, with focus on quality, both with the patient experience and through population health initiatives and quality metric measurement, but also reducing the cost of care. And at the same time, making sure that we're providing a healthy work environment where our physicians, advanced practice providers, and staff enjoy working. So improving the work life of healthcare providers was also important. And the quadruple aim, as we form strategy as an organization, of course, was a guiding light and guiding principle for us as we started to make some decisions, additional decisions about our journey in value-based healthcare. So I'm going to pause a little bit on this slide because there's a lot in here, and this is the references below in the hyperlink for those who have access to the slides, and I encourage you to look at this in the future as well. On the x-axis, you see from left to right, it outlines the level of provider sophistication and transformation. And this is really in that transformation toward value-based healthcare delivery. You see at the far left is the traditional fee-for-service model, one that has been signaled to be shrinking through time. I think it's important to call out right now as we speak this week. Our friends at the AMA and other peer organizations are working in DC to advocate for a reduction in the fee schedule cuts that went into effect January 1st. So the traditional fee-for-service model is on the far left. As you see on the y-axis, increasing is the degree of risk managed by the provider. So how much risk are we taking as the providers in the healthcare delivery system with regards to the financial aspects of the arrangements? So working our way from left to right, fee-for-service, the classic fee-for-service, but then a slight movement into pay-for-activity and coordination. These are still under, I would say, the blue category of payment for services or activity, but then moving up, moving into pay-for-performance, where targets are measured and we are paid for performance on those targets. Getting a little more sophisticated and moving into bundled payments, both in single bearers of risk and risk among multiple providers. Now, these bundles, as we'll talk about a little bit later, can be in specialty-specific areas. So one of my goals as well today is to hope that regardless of your practice size, regardless how large or small you might be, and regardless of your specialty, whether you're a single specialty organization or a multi-specialty organization like us, there are potential opportunities to engage in value-based care activity. Working our way further to the right, shared savings programs. There are multiples of these throughout, and these continue to grow, not only through Medicare, but also through many commercial payers. And then moving into risk. So the shared risk and the global payment or true capitation. You see that this category are all summarized with managing a population. And we'll hit a little bit more on this as well about a different approach to care delivery, instead of it being as much transactional on individual patients, but thinking about our patient panels and our populations as a whole and managing them collectively. So a little bit more about my organization. I work at Hattiesburg Clinic. I've been here about 20 years, as I said. We're a multi-specialty organization established in 1963 by 10 physicians, and we remain independent, physician-owned, in one of the larger in the Southeast United States. So our timeline for value-based healthcare really started in 2007 when we signed our first Medicare Advantage contract. And I will say we absolutely had no idea what we were doing. We learned a lot in those first few years, but it was a good way for us to start down this journey and learn. As we learned in those first few years of this, we recognized that we had a lot of work to do with regards to measurement of our quality, measurement of our costs. And so we made the decision in 2012 to begin the PQRS program. For those of you who were in practice in 2012, you probably participated in PQRS. We participated as a group, the option called GPRO. So that was in 2012. It was really our first glimpse in the mirror, if you will, as to how we stacked up in a value-based care system. And it was not pretty. To orient you on this slide, the y-axis measures quality, and the further you go to the right, the higher your quality is. And on the y-axis is cost. You hope to move up in the y-axis for lower cost. So when we look at this graph, the blue dots represent all the organizations around the country who are also reporting GPRO data. And the goal would be to be in that top right quadrant, or what we call the value quadrant. Well, this was our first look, as I said, in 2012, and it was not pretty. We knew we had a lot of work to do if we were going to evolve and be successful in a value-based care world of the future. So we put a lot of systems in place, a lot of infrastructure, and a lot of planning. And over the course of the next several years, we made progress. We made progress in quality, and we made progress in cost. Ultimately, to where in 2018, we reached that value quadrant and scored in our first year MIPS a 100. So this was our journey. This was a lot went into this, and we'll talk a little bit more about that today. Back to a strategy discussion. As we, as an organization, looked toward the future and at that grim look at our performance in 2012, we started to evaluate care delivery in a different way and envision a future that was different from volume-based healthcare. So the value equation that you see on the top represents quality over cost. And in the left column of the quote, new world, this is a slide from AAPC, this transition from fee-for-service to outcome-based or value-based healthcare delivery. The incentives were not just on a transactional or per click, but also keeping them healthy and being rewarded, keeping our patients healthy and being rewarded for that. And instead of focusing on episodes of care, but again, a broader approach in population, and really examining our role as the deliverers of that care, the physicians and the APPs and our staff on our teams. How do we re-envision the way that our teams are composed as we look toward the future? And then the information. I alluded to earlier our electronic medical record and the importance of having access to data, as we weren't just managing information on a retrospective approach, but also from a predictive approach. So this was part of the strategy and really rethinking the way that the delivery was going to be different in the future. So that was in 2012, as I mentioned, our first glimpse. And over the course of the next several years, we engaged in increasing levels of value-based healthcare delivery. So you see the timeline, it's several years, and I hope that this it ties back to that slide that I previously showed about the progression to value-based care for us as an organization. It was incremental for us. It was some may say slow, but it was intentional and continuous. We are still heavily a fee-for-service organization, but our experiences that we've gained in value-based care over the last many years, I think, has helped us stay independent. That goes back to some of our original decision-making with regards to preparing for the future, is to stay independent. We needed to continue to do fee-for-service well, but we also needed to learn how to do value-based healthcare delivery well. So what were our results? For us, that quality management department that I mentioned started with 2 nurses. It has grown to over about 50 nurses at this point, spread throughout our organization. They're managed centrally, but deployed locally. And we developed standardized workflows throughout the organization that were outcome driven and results driven and really focusing on quality and outcome and results. For those on the call who were in primary care, hopefully you recognize these acronyms: annual wellness visits, CCM or chronic care management, PCM, principal care management, which is not unique to primary care. Some of our specialists are using PCM, and I'll come back to that. TCM, transitional care management, and others. And this is a point that I hope resonates, is that these programs that are listed in this first bullet point are really fee-for-service programs, but they are delivering population health initiatives. They are delivering the items and the trajectory that is toward value-based healthcare. So it has been crucial to our journey is to leverage these opportunities that are reimbursed in fee-for-service to help us deliver better outcomes in a value-based care world. The other things that have happened through the years with the results, we put a lot of work in optimizing the EMR tools. As I mentioned previously, we are on Epic. Those tools are very good. We added to that with what we were able to do within our organization, focusing on our workflows that we were building around population health. And through this journey, we have had consistent and continued improvement in quality indicators. So our patients have been receiving better care because of this work that we have been doing. And that's ultimately the most important thing that we can do. And as a physician, that makes me very proud of this journey, that we've been able to deliver better healthcare, especially in a state that is often known for poor healthcare outcomes, that we've made an improvement in those. So that includes blood pressure and diabetes control, vaccination rates and preventative services, also ER utilization, admission and readmission rates, and patient survey scores. So through this journey in the Medicare ACO, since 2016, we have saved Medicare over $66 million. That is something that we're very proud of, that this journey has saved this Medicare trust fund a substantial amount of money. And we, because we have been a party to that, have shared in value-based care payments across all our plans over $50 million. This again goes back to a bit of a strategy discussion as we looked toward the future, keeping the feet in 2 canoes. Most people have heard that term before, that we wanted to move toward a value-based healthcare system while still participating in fee-for-service in order to stay independent. and our value-based care payments have helped us do that. Throughout this, we've seen continuous growth in our lives in some form of value-based care arrangement, as well as patients have signed up for those or have been attributed to us through the many plans that we're participating in. As you are evaluating your journey and where you stand at this point, the practice assessment, I think, is crucial. And I say there's no better place to start than at cms.gov. Don't reinvent the wheel. Don't go searching for resources that may be more obscure to find. CMS has, in my opinion, done a very good job in outlining what's available. These resources have evolved through time, obviously. These are screenshots that I took just a few weeks ago from the CMS website that really puts a spotlight on value-based care. And it is very detailed in the opportunities that are available now and the vision that CMS has for the future for value-based healthcare. I previously mentioned CMS's or CMMI statement about getting all patients into value-based care plan by 2030. This is also from the CMS website, and in those resources, I would encourage you to look at this, the white paper on the Innovation Center strategy refresh. This was what was announced in 2021, more widely publicized in 2022. But it really goes through a step-by-step approach on how CMS looks at the future. And I think this is very helpful as you examine your practice and do a practice assessment of understanding where CMS envisions the future and the steps really that are maybe necessary to make that journey. On the left side, the website, this is what it looked like in 2018. The CMMI website that was looking at where innovations are happening. In 2018, they had all these dots to represent where were organizations around the country participating in some form of care delivery reform or a new model. You see lots of dots. This was, again, in 2018. And it also, I think, represents to me that a lot of this activity is happening around the country, even in 2018, and the different models that are taking place. Not just primary care-based models, but oncology models, joint replacement models. So those specialty-specific models that may be more applicable to your practice if you're not a multi-specialty organization like we are. On the right, you see what this map looks like now. CMS has updated that website. It's more interactive. And when you look at it a little more clearly, you can drill down and see where these models are happening in places around you. Now back to this image of the progression through time. I would suggest, and I would think, that as you're assessing your practice, you've already participated in something. Something that gives you a signal for where you are on this continuum of, at the far left, fee-for-service, and at the far right, global payment and capitation. Most physicians throughout the country have participated in PQRS or GPRO like us back in 2012, and then the Meaningful Use Program, the MIPS program, of course, and if you're in FQHC, those performance measures. So I think as you're assessing your practice, you've already got a history to look at to say where to get a sense of where you stand, at least on the quality side of things, maybe less so in the cost side of things, but some glimpses into these things. Now we're going to take a little bit deeper look into this practice assessment and I guess our approach and our philosophy on, as you're looking at your practice, what are the things that are foundational as you're examining your journey to value-based care, those that are transitional, and maybe those that are advanced. So as you saw, ours has been a multi-year journey. We had to start at the very basics, those foundational things. So some foundational concepts. It's important to know who your patients are. Understand this population. As you begin to think of value-based healthcare and the care delivery system differently, understanding who your patients are. So that means, are the piece, how do you identify, if you're a primary care physician, how do you identify who your patients are? Is it by knowing who's listed in the PCP field in the EMR? Do you have lists? Also understanding what are your referral patterns? Who, if you're a primary care physician, are the specialists that you're using? Are they part of your system or are they outside of your system? And how readily do you get access to that information? You need to understand the demographics of your population and what is called the quote churn rate. In many value-based care contracts, the population that's assigned to you changes from reporting period to reporting period. And the less of a churn you have in that population, the more likely you are to maybe wrap your arms around that population and manage the population health initiatives around them. So getting a sense of who your patients are, and then as you approach a program, value-based care, understanding how those patients are attributed to you. You saw we're in many programs, and I would say that the attribution methodology is different for every one of them in some way, shape, or form. So having an understanding of who are the patients that you're going to be measured on is important and crucial, I would say. So not only knowing your patients, but also knowing your providers, your physicians, your APPs, that composition. Are you single versus multi-specialty? I believe value-based healthcare can be done in single specialty organizations, private single specialty organizations, even those on the smaller size. What are your panel sizes in the primary care of your primary care physicians? This is crucial. As you approach a population health mindset, it is really managing everyone in that panel. And the larger those panel sizes get, the more difficult it becomes to really wrap your arms around that population and impact their quality and cost. For us, a very unique learning for us was our examination of how we were functioning as a care team. We've shared our story on this with regards to maybe how we were not using our care teams as effectively as possible. And we've made some changes in the way our care teams are composed with regards to physician-led care teams surrounded by multiple team members, including advanced practice providers and case managers and other members of the team. So understanding how your care team's working, and then knowing on your providers how easy it is for your patients to get access. This ties back a little bit to panel size, but are our physicians available on a regular basis to keep them out of urgent care and emergency rooms? Those are crucial pieces that I believe are also foundational. The EMR is a piece of this, of course. A lot of value-based healthcare delivery is impacted by data and having access to that data, but understanding, at least at a foundation level, understanding what current functionality you have for population health. And then how much control do you have over those tools and the enhancements or optimizations that you may want to implement in your organization? Data, as I said, how quickly do you get the data? How much access do you have? How accurate do you feel it is? How complete? And of course, the transparency around it. These are crucial pieces that I think are important as you get off the ground with the foundation of value-based healthcare. Reporting is, of course, an important piece of this, and most people are used to reporting at this point. In one of those programs that I previously mentioned, whether it be MIPS or PQRS, reporting, understanding how you're going to report is foundational. And then, of all the things, probably one of the most important is buy-in and culture. I've got an asterisk by this for a reason, because no matter where you are on this journey, the culture of the organization and the intent of the organization, and then, of course, the buy-in of the stakeholders is crucial as you evaluate your progression or your desire to move further into value-based healthcare delivery. Now, taking a step up a little bit to transitional. So we've established what were some of the more important things from the foundation, but as things get a little more sophisticated, and again, we did not have these things in place as we started in our value-based care journey. We learned a lot of this through several years, really thinking about workflow and how do we approach population health differently. And what tools do you have both in your EMR, but operationally, what tools and workflows do you have in place for improvement in your population health journey? As you get more sophisticated, risk capture becomes even more important. It's important that the healthiness or lack thereof of your population is accurately reflected in risk capture. And there are multiple ways to do this. So getting more familiar with risk capture is crucial as you're progressing in this journey. And then tied really to workflows is how are we messaging to our management and our staff with regards to the infrastructure changes that are needed for care management. This is really important. We spend a lot of time in our organization with messaging and understanding the why. It was crucial to us that all levels of leadership, in addition to the physician leadership, and the practicing physicians, really that the support systems surrounding those who are providing the healthcare, the operations team, the management team, the EMR team, the finance team, et cetera, understood the why, and making sure that you're thinking about that and have the correct infrastructure in place for this transition. Social determinants of health are a crucial piece of care delivery for quality and for population health initiatives, and understanding the impact and the resources that you have available in your communities when you identify areas that are in need of improvement. Education, communication, again, tying back to the why, making this a part of the culture of the organization, not just within the organization, but also to your patients. Part of some of the programs are that you notify your patients that they are in a value-based care arrangement. That's just one piece of it. Really talking about, again, the why, to not just internally, but externally as well. The EMR here transition, I put it here again because the sophistication is greater as you need to understand a little bit more about analytics and what additional reporting capabilities do you have. Do you have, for instance, the ability to attest? So if EMR captured data is not telling the whole story, does your contract allow you to provide supplemental documentation to attest for care gap closures? Really important as you're getting more sophisticated are your relationships with hospitals, as well as specialists that I previously mentioned. Who are your specialists? What are their practice patterns with regards to quality and cost? And for us, another really important space was the post-acute space, those patients who are in between the hospital and home. What type of care is being delivered there, and at what cost is that care being delivered? So having a more sophisticated understanding of that and developing those relationships if you don't have them already. And then understanding the financials a little more clearly, and how will those incremental gains and losses be shared? Every contract, again, is unique, and having an understanding and being able to determine what will lead to success, and what happens if you do have success, but also what happens if you're not successful. And then again, buy-in culture. It goes back to that. For us, as it got harder, we had to circle back to the why. We had to circle back and continuously remind our physicians, our APPs, and our staff this journey we were on and the why behind it. Finally, as we look at the pyramid on practice assessment, the advanced, I would say, we are still learning throughout all this. I hope I can make that clear that we're still on this journey and we're learning. And some of the lessons that we have learned really have only come in the last few years as we've gotten further down this journey. As the advanced topics come into play, it really revolves a lot more around the individual contracts that you're considering participation in. So again, going back to the attribution methodology, how are you going to be measured in quality, and what benchmarks are going to be used? Are you going to be benchmarked to national standards? Are you going to be benchmarked to local standards? Or might you be benchmarked against prior performance that you had internally yourself? So lots of ways that quality can be measured, and having a really good understanding of how quality is measured in those individual contracts and putting programs in place to meet those measures. Likewise, on the quality, similar to the quality, I'd say the financial targets. How are the financial metrics being measured? How are your benchmarks being set? How are you being rebased in those benchmarks? So is it on a year-to-year basis on prior performance, or are you again being compared to regional, local, national standards? Risk adjustment, I come back to that. So all these things have been mentioned, but the level of sophistication needed just gets a little bit higher as you get into more advanced population health and value-based healthcare delivery. Third-party inclusion. This is an important one. Even for us, when we started in the Medicare ACO, we partnered with a convener to help us in those first few years. It was really helpful and important to us because we recognized that we could not do this by ourselves. This was a steep learning curve for us. And so consideration of where on that journey you are, and is there a need to include third parties for many of the things that I've already mentioned. And it can be just for certain pieces of it. And then having a really good understanding of what is in your control and what is out of your control with regards to those contracts. And as you negotiate those contracts, if there's any room for negotiation, but having a clear understanding of what you can impact and maybe what's out of your control. The EMR, as you go further down the journey, having not just look back, but also real-time predictive modeling, understanding the likelihood of your population going to the emergency room, which patients are most likely to be in the emergency room or be admitted, and using that information and data to craft programs around your highest risk populations. Advancing care management, that's how we manage those higher risk populations. Our care management services have certainly gotten much more sophisticated through the years as that quality management department has grown. It's not just about taking an inventory or filling out a questionnaire, but it's really getting to the heart of how can we do better case management for these patients that are in our value-based care contracts and in the populations we serve. Continued focus on social determinants of health is crucial as you advance, as these are significantly impactful in value-based healthcare delivery, and understanding not only where your patients are in their SDOH, but also what resources you have available to assist them, and if not within your organization, outside of your organization. Care coordination across the continuum. This goes back to that relationships with hospitals, post-acute facilities, long-term care facilities, etc. These relationships are really, really important, and having coordination among those entities so that regardless of where the patient is on the continuum of care, inpatient, outpatient, or somewhere in between, wellness, disease prevention, or if they're really sick, that there is care coordination amongst those different entities. And then finally, of course, buy-in and culture. This is for us has been, we're reaching levels of sophistication that we certainly didn't have in place many years ago, but it was important throughout this whole time to continue to come back to the why, and guiding this from the beginning has always been that we're delivering better healthcare, and that's something for us to be proud of. All right, as I wrap up, I want to circle back to that this is a journey. We are still learning. We've been doing this for many years, and we are still learning. But I truly believe that no matter where you are, whether you're an independent practice, a small practice, multi-specialty, or a larger one, that there is a place that you can plug in on this image. And if you choose, as an organization, work your way from left to right, if you so choose. So I would say start, even right now, if you're exclusively in a fee-for-service position. I think there are opportunities to use a fee-for-service system and in a good way to provide better health care to your patients. So population health initiatives happen in chronic care management, CCM, PCM, TCM, et cetera. So if you're at the far right, I think there are ways to begin thinking about how you're managing a population in a different way. And then as you look at transitioning toward more advanced models and higher risk, certainly evaluate the options that are available to you and are most applicable to you. Look at both government payers. The CMS website I referenced is a good place to start for government payers, but also commercial payers. As your sophistication grows and your appetite for taking on risk grows, think about your commercial payers and see what opportunities they might have to participate. And then just like we did, consider partnerships. Look at opportunities, conveners out there that may make sense for you to facilitate your progression and also reduce your risk. CMS has introduced many models. Some of them are even prospective payment models and to mitigate the risk for the entry point. So I think there are options out there that I believe are available to most anyone who's willing and interested to take a look at this journey similar to us. So that was our story. I hope you found it helpful as you look at where you are and look at maybe how you want to think about your future, maybe in a different way. So with that, I'll turn it back over to Sumbul.
Thank you, Dr. Batson, for your time today. I'd like to encourage everyone to visit the discussion board, which is located on the right-hand side of this webinar, to connect with Dr. Batson and peers on value-based care. There will be weekly prompts that Dr. Batson will be posting. Next slide, please. And this is our first one to start us off. Week 1 is to assess where you are on this progression from fee-for-service to global payment on a scale of 1 to 8. We'd love if you could post your responses and thoughts in that discussion board. Next slide, please. And that concludes our presentation today. Thank you all for joining us.